Hello, everybody. Sorry, we're starting a minute late. We were having some AV difficulties as usual. Seems to always happen.
Yeah.
But welcome to this month's webinar. And this month we're going to sort of talk about cancer risk and cancer patients and hormone therapy, because I know it's been coming up. Amy and I have been seeing more and more patients coming in saying, well, I watched this TikTok that said that it doesn't matter that I had breast cancer. It's fine. You can have hormones, or, people have all sorts of crazy ideas about the risks of hormones and cancer. So we wanted to sort of address a lot of those topics in one place. And I'm happy to welcome Dr. Amy Vodish again to a webinar with us. She is always willing when I ask to come and talk to us. So Amy, give us a quick, 2-minute about who you are for those who haven't seen you on a previous webinar.
Yes. Well, thank you for having me back. It's so fun. So I'm Dr. Amy Vodish. I am an attending at Stanford University. I am a complex family planning expert and also a menopause expert. And Dr. Dunsmore Sue and I have a podcast together. So we always love to talk all things hormones at all times. I am not an oncologist. I will just preface that by saying that. So just even though I'll kind of give my spiel, my 2 cents on kind of these topics at hand. It's not my background training, but it's definitely something that I talk about on a daily basis.
And that's a really great point. The goal of this webinar is, how does the menopause provider counsel about these topics and these ideas? Obviously, if you have a cancer patient, they should be talking to their oncologist about these things. And that's one of the counseling points I always start with is, please go back and talk to your oncologist if you have questions about this. And just to remind everybody who's in the webinar, we're going to sort of go through some talking points, ask each other questions, and then at the end we'll leave lots of time for Q&A. So if you think of a question, you want to stick it in the chat or the Q&A right now, that's fine. We'll get to you at the end and answer questions at that time. And we like to spend a lot of time on that. So we have a lot of things to cover today, but I think that I want to start with, we have all heard that combined menopausal hormone therapy, so specifically estrogen plus a progestin, increases the risk of breast cancer by 1 additional case in 1,000 woman years. And that's a number I think we all used for counseling.
Yep.
Can you maybe put a finer point on this for us? Like, is it because the hormones are causing the breast cancer? Is it the same if we're using estradiol and micronized progesterone? Or are we continuing to quote the WHI in a generation where we're not using those meds anymore?
Yeah. I mean, I think that's a really good point, right? Because there's a lot of thought out there, and this has been big on TikTok, big on social media. We don't use the drugs in the WHI study, so that data no longer applies to kind of what is current medicine or, current practices. And I think there's maybe a little insight to that, maybe a little truth, but I don't think it's not as black and white as it's being made out to be in TikTok. So basically, I don't think that estrogen and menopausal hormone therapy causes breast cancer. I kind of view it as like another modifiable risk factor that may be associated with breast cancer risk. So when we think about, when I do counseling for folks, there's a lot of things that can increase your risk of breast cancer. They don't cause breast cancer per se, but they sort of increase the risk of it developing in your body, is kind of the way that I think about it. So
great way to put it.
Yeah. So what are other modifiable risk factors? Alcohol intake, obesity, sleep apnea. Like, these are things that we know can impact and sort of influence the trajectory of whether or not we may develop breast cancer in our bodies. And so that's one of the things that I kind of think about it. So I tell patients, like, this isn't going to cause it to happen, but it can potentially increase your risk of it developing. And so we have to think about it when you put all of your medical history together. Like, does it make sense for you or does it not make sense for you? And I do like the absolute increased risk, because I think that's helpful, because again, depending on what social media channel you're on, it might be, especially if it was a few years ago, hormones are terrible, they're going to cause breast cancer, you're going to die from it. Or, nah, there's no increased risk at all, it's totally overblown, so don't worry about it at all. So I think it's important to still kind of talk about the data. So that's part one. So that's kind of one part of the counseling.
Right.
But I think
And I actually wanted to add something to that because sometimes I like to you have a great way of phrasing that it's one additional modifiable risk factor. I tell patients if you think about cancer develops because of genetic changes in the cells. That's what causes cancer. And there's so many things in our lives that can increase the risk of that happening as we live in this world and experience cosmic radiation and microplastics and all those things. So this is just one of those other things. But I say, if estrogen and progesterone caused cancer, then 100% of women would get breast
right,
cancer because
right.
we all spend 40 or so years with estrogen and progesterone cycling in our bodies. So obviously it doesn't cause it. It's just a risk factor.
Yeah, exactly. I think that's a really good way of
Hmm.
putting it. And then I think the other part of your question is whether or not the newer formulations have a lower risk. And so when we talk about newer formulations, we're mostly talking about estradiol and micronized progesterone. That's kind of our most
Hmm.
common, right?
Right.
And when we look at the data from the WHI study, that was with conjugated equine estrogen and medroxyprogesterone, which is a progestin. And so there have been some observational trials that have come out to kind of look at, they call it, a lot of the studies will call it like contemporary menopausal hormone therapy. So is there less of a risk with
Sounds
estrogen?
very fashionable.
Very fashionable, contemporary. Um, and a lot of that data is observational studies. So we don't
Right.
have a lot of randomized control trials. And with the observational data, I think you see a little bit of kind of some say that there's less risk with estradiol than with conjugated equine estrogen. Some studies are saying it's the same. Because one of the things about the WHI study was that the conjugated equine estrogen arm alone actually didn't have an increased risk of breast cancer associated with it. And some of the data was indicating perhaps a decreased risk of developing breast cancer. And so does estradiol have the same thing? And then the other question, of course, is, well, we don't really use medroxyprogesterone. It was the estrogen progestogen group that had that increased risk. And so if we use a different progesterone or progestogen, might we then have a slightly decreased risk of breast cancer? So some of the studies have shown, some of these observational trials, kind of one of the biggest ones out there is that the E3N study, which was like a massive study out of France with like 100,000 people. It's incredible the stuff they've looked at. I mean, you can just.
And they download it every 5 years and give us new data.
I know, which is interesting because then the data changes. Like some of their results from 2014 are different than their results from 2019 or whatever. So it's kind of interesting as they're like, oh, actually, we watched this a little longer, see what we found out.
Yeah.
So that very long, large observational study is showing that perhaps micronized progesterone may have a lower risk of breast cancer than a synthetic progestogen. So, and I just saw a question pop up saying, what study was that? It's written in like a very long French word, but if you put in the capital E, number 3, oh my gosh.
Capital N.
Capital N, thank you. Perimenopausal brain fog.
E3N.
The E3N, and there's tons of data. It looks at like air pollution. It looks like antidepressant use. It looks at like depression incidence. It looks at alcohol. I mean, it looks at like a gajillion different things.
It's basically a download of their nationalized health system. But one of the things that they download is all the women who received and refilled prescriptions for hormone therapy, whatever that might be, and if they were diagnosed with breast cancer.
So there's some interesting thoughts there. Like, does micronized progesterone have a decreased risk? Is there a difference in like if you only use it for 5 years versus if you use it for longer? So, but this is all observational data. And what we don't have is and we probably will never get.
I know.
Think again, randomized controlled trial to really show it. So I haven't necessarily changed my counseling on it. I still sort of say, maybe these other formulations, some data is showing perhaps they have a slight decreased risk, some data is showing it's the same risk. So I still quote, like, I can't tell you that there isn't an increased risk. I can't say that being on estradiol and micronized progesterone is safer for you from a breast cancer risk perspective. I mean, just because we have sort of a variety of different studies that are out there, because there's some like Finnish studies that have come out that have looked at it. So it's kind of an interesting, I think it's kind of a little bit of a hodgepodge when I sort of try to put it all together in my brain. Sometimes my brain gets a little bit muddled when I look at all the different, like,
I know.
studies on
I
it.
totally agree with you. And that's how I counsel as well. You know, I tell people there are a lot of influencers out there saying, oh, if you use micronized progesterone, there's no risk. Well, that's not what every study tells us. So I don't
No.
feel like that's good counseling
Yeah.
for us to do. You know, I tell people this is the best risk estimate we have from a randomized controlled trial. It might be a little bit lower, but I can't say that for sure. So you need to go with this risk.
Yeah.
And decide if this risk is worth it for you.
Yeah. I kind of sort of look at it as like worst case scenario, this is probably as high as it is.
Yeah.
So put that in with kind of your personal computer where you calculate your risk profile and decide what's going to work for you or not.
Yeah.
It's sort of the way that I think about it.
Right.
Yeah. So, I mean, does any of this change how you counsel patients? Because all the patients who come in and they're like, well, I'm in a higher genetic risk. Does that change anything for you in terms of like how you counsel them?
You know, I love this question. And I love this question because I think for years, women have been told if you have a strong family history of breast cancer or your lifetime risk is 20 or 30%, you are not a candidate for hormones. And, you know, some of these women are really suffering. Like they're having tremendous menopausal symptoms. And I love talking to them because what I can say to them is that is absolutely untrue. Your risk is your risk. You know, those risk calculators are wonderful for determining your screening pathway. That's what they're made for. They should inform whether you get mammograms every year, whether you alternate mammograms and MRIs every 6 months, because that's how we detect cancer early. But the attributable risk due to hormone is the same for that woman as for anyone else. For her, it's still only going to increase her risk by one additional case in 1,000 woman years.
Right.
That's it. You know, it doesn't multiply, it doesn't, make it 4 or 5 or 6 times as risky. It's the exact same attributable risk for that population. And, I think our oncology colleagues are coming to that realization as well. We see them being much more comfortable with their BRCA patients who are going to get a nephrectomy, using hormones at least until the natural age of menopause so they don't end up with cardiovascular disease and bone loss and all those things.
Right.
So I think, being able to parse that out for someone who's been told her whole life that she's at high risk for breast cancer and can't ever have a hormone and she's really struggling is a wonderful thing to do. I think, and that's true of any genetic syndrome, whether it's just a strong family history, an actual identified genetic risk, the risk is their risk. You're really not impacting it any more than you impact anybody else.
Right. Yeah, exactly. No, I think that's the way that I will counsel as well. And it's hard getting sort of the primary care. I mean, I just had a girlfriend who was like, well, my doctor says, with my previous history of a breast biopsy and my dense breast tissue, I can't have hormone replacement therapy. And I was like, this is not like, no. I'm just like, we've done so much work on this. You know what I mean? The funny thing is we share the same primary care doctor. And I was like, I have talked to her about this. Clearly my work here is not done, but I get it. They're nervous, right? And this is not their area of expertise. So
nobody wants to feel like they caused breast cancer.
No, right? Like it's the first do no harm thing. But sometimes I think we get so nervous about it, right? It makes it. Yeah.
And bringing up do no harm, we have to remember what harm we might be doing by not starting them on hormones.
Right.
Especially if they're really suffering from a quality of life perspective or if they're really high risk for osteoporosis. Is this person more likely to get breast cancer or break a hip? We got to balance all of those things.
Right. Yeah, absolutely. Absolutely.
I think both of us are seeing a lot of women come in who've had breast cancer, or they've had DCIS, or they've had LCIS, or they've even had atypical ductal hyperplasia. And they want to know if they can use menopausal hormone therapy. And I see this especially in people who are diagnosed with like the DCIS in their 30s, and now they're going through menopause in their late 40s. they're 10, 15 years out. They're like, my recurrence risk is so tiny. Can I just, be a normal person again?
I know.
Is there a time period after which you would consider it? Is there any point at which you would say, okay, maybe?
I mean, I think it's tough, right?
Yeah.
So that is again one of those conversations like in conjunction with their oncologists if they're still seeing them. And I
Right.
have a big conversation about quality of life. Like if
Yeah.
because I've had some patients that, have a history of DCIS, they're all done with therapy, they're not doing anything else, but their quality of life is so poor that they
Right.
literally will say, I would rather die than continue to live like this. And you're like,
Right.
okay, we need to have this conversation. Like,
Right.
I'll take the small potential risk of,
Mm-hmm.
the interesting and hard part about DCIS is like, did you get everything? Are we missing something? Would this be, of
Mm-hmm.
all the little insults that you're getting to increase your risk of recurrence, is this the one that's going to like tip you over the edge?
Right.
And that's
And
hard,
many DCIS patients had a lumpectomy. So we don't know that there's not another focus in their breast.
right? Which is really challenging. And then
Mm-hmm.
there's like DCIS that's not going to recur and DCIS that has a really high chance of recurring. And I think we sort of lump all the DCIS patients together. And what would be so helpful would be, can we do a better job of identifying those where, that we really don't have to worry so much about that.
Right.
And I know that there's ongoing trials looking at that, which is,
Right.
very
Because we
exciting.
just don't know, right? We
Oh,
know that like 20% will progress or recur, and we just don't know which 20% that is.
right. And so I think that's where it's definitely like the shared decision making
Right.
conversation. In general, I don't prescribe menopausal hormone therapy for folks with DCIS, but
Mm-hmm.
there's an art to medicine, and nothing, very little is black and white. I feel like in menopausal care, there is definitely some things where you're like, I'm sorry,
Right.
you're not
Yeah.
getting hormones, but
Yeah.
like, but there are some things where you just have to have, that conversation. That's kind of
Right.
the way that I look at it.
And there have been some small trials of this, right?
Yeah. Yeah, there have been a few trials. So it's interesting. So there was one called the Habits trial, which was
Mm-hmm.
done in Scandinavia in the 90s. So that was kind of
Right.
an interesting study because it was a randomized control trial. It really wanted to sort of answer that question, like, is
Mm-hmm.
it safe to give menopausal hormone therapy to people like status post like low stage breast cancer? Like,
Yeah.
can they finish treatment for their cancer? What happens if we give them menopausal
Right.
hormone therapy? So they did it, and they randomized. It wasn't a huge study, but it was like 400 people, and so
Mm-hmm.
and they randomized them, and they did a follow up, but the follow up was only about 2 years, so it wasn't like a long
Mm-hmm.
follow up. But
Right.
when they looked at it, they looked at the folks in the menopausal hormone therapy group and the folks without, and there were um, more women in the HRT group developed a recurrence of their breast cancer.
Right.
And so they decided on that it was an unacceptable risk. And so the trial was terminated after not very long.
Yeah.
Um,
And there was a second trial running at the same time, which was also terminated based on the results of the first.
right. Yes. Yeah. The Stockholm trial. I know. So the Stockholm trial was trying to do the same thing. And then and then the Habits trial came out, and they're in
Yeah.
Stockholm trial, were like, and we're done. But they
Yeah.
were kind of interesting because they actually didn't really see the same findings.
Right.
Um,
They hadn't seen it, but they hadn't gone as long yet, I
they
think.
hadn't gone as long. And so
Right.
that was kind of interesting. So there were some folks who were looking at it, and we were trying to get the answer to that question, but then,
Mm-hmm.
so we
Right.
just, it's
They
really
they
kind of
met
like,
their safety stop point and they stopped.
and they stopped. And that's what safety stop points are
Yeah.
designed for in randomized controlled trials. So I
Right.
think this sort of social media trend of like where people are coming off being
Mm-hmm.
like, oh, I don't know, like there is no new data
No.
that is out there that is now saying, oh, we've been too strict about this. Like we really need
Right.
to sort of loosen up on it.
Right.
But I think there's just such a push for people who have suffered for so long. And I totally get that, for being like, hey, we need to loosen up restrictions on
Right.
everybody. It's like, well, we don't really have the data there. Right. So
We don't. We don't.
what do you say? I mean, how do you counsel? Like, I'm
No.
assuming because you and I are relatively similar in all of our things,
Yeah.
but like, is there any finer nuanced points that you put on it?
Well, the one nuanced point I sometimes go to is do-a-V. And for
Yes.
those on the call who aren't that experienced with Duovy is a combination of conjugated equine estrogens and basodoxifene, which is a SERM. And it is a SERM that specifically is anti-estrogen at breast cells, but also anti-estrogen at uterine cells, which is great because it acts as the progestin arm of combined hormone therapy. And the reason I sometimes bring that up, the place where I'm most comfortable bringing this up is in my patients with atypical ductal hyperplasia.
Yeah.
So this
Yeah.
is
I agree.
pre-DCIS. It's not even as likely as DCIS to progress to cancer. And oftentimes these patients are offered something like a tamoxifen to reduce their risk of developing cancer, and basodoxifene is a great option for them. We don't have it outside of this combined form in the US. It's available in Europe as just basodoxifene.
Yeah.
Unfortunately, we can only get it combined and do a V here. But the reason I bring it up is because we do have some pretty good data that basodoxifene itself reduces proliferation of breast cells, and it
Hmm.
functions as well as tamoxifen as a SERM to prevent breast cancer development.
Right.
And it seems to do that even in the setting of having the conjugated equine estrogen along with it, which makes sense to us because in the WHI, the CEE also slightly reduce the risk of breast cancer. So
Right.
you're sort of using two meds that should have the same push. Now, would I use this in someone with DCIS? I don't know. Sometimes I do. Again, patient is really struggling. I feel a lot more comfortable using a Duovi than I do estradiol and micronized progesterone for them.
Right. Yep.
Um, and there are studies being done on that right now. They haven't resulted yet.
Right.
But there are also some interesting small basic science studies that look at markers of breast cancer in the blood, circulating in the blood in women on and not on Duovi, and show that those markers are much reduced in Duovi. So we have hints that this might be
Yeah.
a pathway we're going to have to go down. Now, would I use it after stage 1, stage 2 cancer? Still probably not.
Yeah.
I
Yeah.
don't think their oncologist would thank me if I did. Uh, But again, this is something you can at least tell patients about. Maybe they can bring it to their oncologist and see how they feel about it. That's maybe a stretch too far for my liability insurance if I start doing that. But it's something that we're getting increasing data on, and
Yeah.
it's promising. I think because especially as women who get DCIS in their 30s, who might then even get a BSO or something like that, like
Ah,
you got to worry about their bones, and Duovi would protect their bones because
You know,
both the SERM and the estrogen protect bones. So,
I would basically give just about anything for benzodiazepine to be available as a standalone product
me
in the
too.
US. Like it could solve a lot of our issues and side effects that people have
Right,
with taking progestogen therapy.
right.
So I know. So I think Duvi is really exciting. It wasn't on the market for those of you on the call who maybe aren't super familiar with it. It wasn't on the market a lot during COVID because of
Hmm.
the blister packaging. There was a shortage of the blister packaging, which has now
Right.
been resolved. So now you can get it again. But then, of
Yes.
course, the big issue is getting it covered by insurance
Right.
because it
And a
is.
little hint for all those out there in the ether, there are some pharmacies that do a good cash price on this. I think the one I typically send it to is Blink RX, and they
Mm-hmm.
have a pretty decent cash price if their insurance doesn't cover it. But I've actually had really good luck. It's not that expensive a medication, so I've had pretty good luck with the prior authorization on Duovi. So if somebody has had ADH, I just say there's no other option for them. They must have a SERM involved in their menopausal hormone therapy. And I usually get a yes at that point.
Oh, that's good to know.
Yeah.
Okay. To think about
Um,
my wording for my
are there
product.
other cancers that we should be talking about here? We've talked a lot about breast cancer, but what about other cancers that menopausal hormone therapy might alter the risk of?
Yeah, so this is a big one. So we talk about, I mean, the big one we always talk about, right, is that estrogens stimulate the lining of the uterus to grow. Potentially unopposed estrogen could lead to endometrial hyperplasia or,
Hmm.
cancer. And so that's one of the things that we always think about. So, but as
Hmm.
long as you're pairing it appropriately with progestogen therapy,
Right.
you actually don't see an increased risk of
You see a
endometrial
decreased
cancer.
risk.
You see a decreased risk of endometrial
Yeah.
cancer, which is kind of crazy. So when you compare it, and that's what I'll tell my patients, I'm like, listen, if it's appropriately paired, you're actually going to have a decreased risk than somebody who's not on the medication at all.
Right.
So that's kind of one of the
and it's a pretty decent decrease. I think in the WHI it was a pretty decent lowering of endometrial cancer risk.
It was.
And we're seeing more endometrial cancer as we see more obesity, especially in older women.
Right. Yeah, absolutely. So that's one of those that I always talk about that as a potential risk of being on estrogen, but I use it more to explain why we're adding the progestogen to it and why you have to have that there. And then one of the other questions I get from folks are like ovarian cancer. Does it increase my risk? Does it decrease my risk? There may be a slight increased risk, but if there's one that's there, because there have been some interesting studies sort of showing no increased risk, some showing a potential slight increased risk, it's extremely low, like even less than that potential breast cancer risk. So I'll sometimes quote it as like 1 in 10,000 kind of a risk, give or take. And so that's one of those things where like it may slightly increase your risk, but it's not something that I'm like overly like worried about. I don't change my, my pelvic exam. I don't change any of my screening protocols or any of that type of stuff. So somebody's on MHD from an ovarian cancer perspective.
Right.
And then the other one, of course, is colon cancer. Right. So the WHI study did show a lower risk of a colon cancer, especially in the estrogen and progestogen group combination. So that was one of those like, oh, look, we have a slight benefit of that. But we haven't seen it as so much, I think, in other studies that have been out there. So I think if there is any sort of protection, it's probably pretty weak. Like we certainly don't.
And the other thing I've seen is that it doesn't carry over. So it's not like you took it for 5 years and now you have this protection lifelong. It's while you are on the MHT.
Right. And as soon as you go off that, that protection is gone.
Yeah.
Those are sort of the three main ones that I'll talk about. When there's a good question that just popped up in the chat about like, what if somebody has endometrial cancer, status post therapy? Are they a candidate for hormone replacement therapy or menopausal hormone therapy? So generally in conjunction with my gynecologic oncologist, if somebody's like a stage 1, stage 1A, we're good, like they're kind of like all is well in the world. We generally don't seem to have a big issue with being on hormone replacement therapy in that group.
No, and that's the experience I've had with GYN oncology as well, is if it's stage 1A, if it's completely cured with surgery and they're fine, then yeah. I mean, they've changed so much about how they even follow those patients up now. Like they don't need to go back to the oncologist. They can have regular exams at a regular schedule. So I think, I think there is a role for hormone therapy in some of those early stage patients.
Yeah, I agree. I think all the different ovarian cancers, I think it really just depends so much. Like if you have a history of ovarian, like what kind of cancer and kind of like what's happening, like what's the whole picture that's going on here. And so that is super, at least for my patients, has been pretty complex. And so it's kind of a case by case basis of sort of.
Right. And that's definitely where you have a conversation with the GYN oncology team.
Yeah, %. I'm like, there's a lot going on with that one. So I generally like, let me just refer back to them and we'll see what that conversation is. Yeah. Yeah. So one of the things that I think is super interesting are sort of how our counseling differs when we're talking about like different populations. So one of them in particular that you and I have a particular interest in are those who go through premature ovarian insufficiency or premature. They kind of go through like premature menopause, premature ovarian insufficiency. Like how does your counseling change for those patients? Because they're different than somebody who's going through menopause at 51, right? They are
very different. And just for some on the call who might not know the definitions, premature ovarian failure or premature ovarian insufficiency, we used to call premature menopause, is anyone who goes through before the age of 40. So cessation of menses before 40. What we really have to think about here is balancing all of the risks and all of the benefits. And so we know that starting these patients on hormone therapy and continuing that hormone therapy at least until approximately the natural age of menopause, around 52, decreases their risk of long-term bone complications, osteoporosis and hip fracture, decreases their risk of cardiovascular disease long-term, decreases their risk of dementia in later
Hmm.
life.
Yes.
And that's the one place where we have that data. And
The others,
so,
yeah, an
and the quality
actual
of life
prevention of
can
dementia.
be life-changing.
Yes.
There are a couple things I do when I'm counseling those patients because they have heard that menopausal hormone therapy is bad for you, it's going to cause them breast cancer. What I
Hmm.
tell them is that is data that is taken from women who had gone through menopause over the age of 50 or over the age of 45 at least.
Hmm. Yeah.
So we cannot apply that data to you. You are in a time of life where you would have these hormones.
Yep.
You are supposed to have these hormones. So that data is about using those hormones beyond a natural menopause. You don't qualify for that. Those risk estimates apply to you once we get you to that milestone.
Yeah.
So, you are supposed to have estrogen and progesterone floating around in your body right now. And so we need to replace those because here is where I would actually genuinely call it hormone replacement therapy instead
Yep.
of menopausal hormone therapy. And I know
They're
we've
actually
changed the terminology.
they're totally different. I
They're
mean, they're
totally
the same
different.
medications, but they're
Uh-huh.
different doses. There's a
Right,
different indication. It is
right,
not the same.
right.
This is apples and oranges as far as I'm
Right.
concerned.
And we should probably do a whole webinar on premature ovarian insufficiency. There's so much to talk about there. I do definitely want to bring up, you have to be sort of aware of where they are in the process of POI. Are they still throwing out an egg from time to time? Do they not want to become pregnant? Do we need to contracept? Sometimes starting them on hormones can get them to ovulate a few more times. There are a lot of considerations that go into it.
Yep.
But I think the risk benefit discussion for them is completely different. Like it's almost all benefit with very little risk for them, really up to the age of natural menopause. And we should be replacing them and at higher doses. So I know you and I are probably pretty much the same. I typically start them at a zero point 0.1 patch
100%.
and 200 of micronized progesterone at night if they don't want to bleed, or we can do cyclic if they want to feel normal. But yeah,
Sounds terrible, but yeah.
yeah, I know. Why anybody wants to have a period, I would never know. So I think we've addressed a lot of the questions that have come up, but let me see. Um, would you be able to touch on patients with endometriosis who are good candidates for MHT since it is estrogen sensitive? What do you do with your endometriosis patients, Amy?
Yeah.
That's a great question. Thank you for bringing that up.
Yeah, it's a really good one. So I will, so a lot of my endometriosis patients have had a hysterectomy for treatment of their disease. And so
Mhm.
technically they don't need, endometrial protection with a progestogen, but I often will put them on progestogen therapy because they
Mhm.
probably have endometrial implants other places. And so just from like a prevention of pain, prevention of, flare up of disease. And then also just, it's kind of that interesting question of like, it's very low risk, but could there be, malignant conversion within those endometriotic implants?
Right.
So I think, so for me, I'll often put them on progestogen
Mhm.
therapy, unless for some reason they like cannot tolerate any progestogen therapy for any reason. Some people don't tolerate them well, but otherwise that's my general go-to. How about you?
I typically do the same thing. Sometimes I'll have a conversation with them. Are we going to do this forever? Is it always going to be combined? Do we maybe do 5 years of progestogen and then go to straight estrogen as we get further out and the doses are lower? It's art, not science. We really don't have
100%.
data in this. But I think
Yeah.
in general, I do add a progestogen, especially in the first couple of years for those exact reasons.
Yeah.
Um, you know, I think that there's very little data on actual conversion to
Yeah.
endometrioid, like peritoneal cancer from these. But, in theory, I suppose it could happen.
I
So,
know. I say, I'm like, it's probably more of a theoretical thing versus like,
right.
I think it's very unusual, but
Mm-hmm.
I mean, I have someone right now where she had a morcellation. So it's
Right.
studded all over her
Right.
abdomen. Like you can see all the little implants on MRI. And so you're like, oh, that's interesting. Let's put a
Yeah.
little progesterone in her, make me feel
Put a
better.
lot of progesterone, all
Yeah.
the progesterone.
I'm like, can I just put an IUD, like just staple it, like
Yeah.
20 of them all over the inside of
Okay,
your
we're not
abdomen?
really going to do that, by the way. We
No,
don't staple
no,
IUDs into the peritoneum, but
no, no.
you get the
Like a
picture.
complex family planning person can dream.
Yeah, I know. The non-uterine IUD
Yeah.
on purpose instead
On
of by
purpose.
accident. Yeah. Does anyone else have any other questions before we sign off? Because I think we've sort of covered a lot of different topics, and I know I'm trying to see if there's anything else. Oh, somebody did send it to BlinkRx and got a great price on Duovie for $30 a month. Yeah, that's my experience too. Duovie is not so baseline expensive that you can't get a good coupon price.
Yeah.
Um, can you address HRT pill versus patch versus cream, and is there an age where you say stop? So first, I'm gonna start with the pill versus patch versus cream. Estradiol cream is for your vagina. There is no cream for systemic use. Now, some people compound it. We never recommend compounding. There is no reason to compound. It's always less reliably dosed and never better.
Hmm.
So don't do that. Pill versus patch. We tend to try to start with transdermal. Transdermal tends to be best from a clot risk perspective, but there are really good large observational studies that show that women under 60 who take oral estradiol really don't have an increased clot risk either. So, if someone's low risk and young, it doesn't matter. Use the format that's going to work for them.
Yeah.
If someone's not doing well with a patch, either because of skin irritation or they're not absorbing it well, I'll switch them to a pill. I think that's fine.
Totally.
And there's gels, there's vaginal rings. I love the fem ring and nobody can get it covered. But
Yeah.
if we could get it covered, it's great. Amy, what do you say about, is there an age where you stop? And
No.
the age to stop is not based on cancer risk. The cancer risk is,
Yes. The cancer risk is what it is.
yeah.
That doesn't change. So the
Hmm.
where this whole idea came from that you needed to stop hormone replacement therapy or menopausal hormone therapy at a particular age was sort of poor extrapolation from the WHI study, where the
Right.
WHI study showed that if you start or initiate hormone replacement therapy after the age of 60 or more than 10
Hmm.
years from menopause, there was an increased risk of heart attacks and strokes and dementia. And so there came this thing. We're like, oh my gosh, if you're over the age of 60, you can't be on hormone therapy. It isn't
Right.
about continuation, it's all about initiation. So
Yeah.
I had patients so what I tell my patients is you can be on this as long as you want to be, as long as we feel like it's beneficial for you, that the benefits are outweighing the risks. And the reasons why you have to go off, I generally quote like about five. They develop they personally develop breast cancer. They have a heart attack. They have a stroke. They get a blood clot in their legs or their lungs. They have
Hmm.
out of control biliary disease. Like those are reasons why you medically need to go off it. But otherwise, if you're feeling like for you, it's improving your
Hmm.
quality of life, we're still addressing whatever particular, issues we went on it to
Hmm.
start with. Um, so I don't say you have to go off it. Now, if folks are on it and say they started it for hot flashes and they've been on it for 5 or 8 years or whatever, I might say, hey, do you want to, if the only reason you went on it were for hot flashes, about 80% of people, their hot flashes resolve as they get sort of further into the process. So do you want to do a trial off to see if you still need it? You certainly can. You don't have to. So I kind of just have that conversation out there with them, but I certainly
Yeah.
aren't like, oh, you've reached 60, you've reached 65, you need to go off, which is a big thing that a lot of primary care doctors will tell
Right.
patients because it's, again,
But
a new
that's how they were trained. In all honesty, that's how
Yes,
we were trained.
yes.
And we've just learned more over time. I tell my patients, I say I have three groups of hormone therapy patients. I have the ones on it specifically for hot flashes. They tend to do it for 5 to 10 years, and then their hot flashes are gone and they stop. And then I have the ones in the middle that had hot flashes maybe, but also had brain fog and sleep disturbance and all these other things. And they're high-powered executives, and they do not want to come off that hormone therapy while they're still working and trying to function in the world and getting their kids off to college. And they tend to take it until they retire. And then maybe they decide they want to do a trial off just to not be on a medication. And my third group are planning to take it forever and will take it forever because they feel better on it. Whether it's joint pain, whether it's brain fog, whatever the thing that's making them feel better, they feel better. And that's okay too. And they're probably about a third, a third, a third in my practice. My favorite patient, and I'll give one little story and then we'll go on to the other questions. My favorite patient ever was 94 years old, and I was rewriting her HRT prescription every year. She was on a 0.025 patch. She'd had a hysterectomy. And she came in, she said, "Oh, my doctor said I should probably stop this now." She's like, "But I just turned to him and looked at him and said, 'What's it gonna do? Kill me?'" So I'm
I
like,
mean, what are we
"You've got a
doing?
point."
I've got some little 80-year-olds. We're doing
Yeah.
our thing, like
Yeah.
they're just like, nope, I feel like it's doing
Yeah.
all the things I needed to do. So no, it's very
Great.
sweet.
Somebody asked if we repeat the numerical risk factor that MHD can alter breast cancer. So we quote the WHI. One additional case per 1,000 woman years, and that's just how they calculate it. 1,000 women for 1 year or 10 women for 100 years. It's 1,000 woman years. It's really actually 9 additional cases in 10,000 woman years. So technically, you could say it's 0.9 additional cases in 1,000 woman years, but nobody has 0.9 of a case. So one is, what I usually quote.
Yeah.
Amy, someone asked, do you determine transdermal E2 not being absorbed well by symptoms only, or is there a role for an E2 serum level?
Yeah. So I rarely check serum levels, but this is
Mm-hmm.
one of those cases where I will. So if someone's on
Okay.
transdermal and we're on a dose where I think they should help, or maybe they're on a
Mm-hmm.
dose, they're like, oh, I'm still having symptoms. I go up to the next dose. They're still
Right.
having symptoms. It hasn't touched it. Nothing's improved. Then
Right.
that's a case where I might check an estradiol level to see if it's being absorbed. And actually,
Right.
sometimes I'll even check it for people who are on oral. So let's say, for example, maybe they're on a GLP-1 or
Mm,
they've had a bypass surgery or something like that. And they're like, yeah, it was working and it's not working anymore. And I start, so then I might be like, okay, are we having a GI absorption problem for some reason? Or
yeah.
maybe they started a new medication that's impacting absorption, something like that.
Right.
Mostly it's so transdermal, are we absorbing well through the skin?
Yeah. And, I do the same thing. I typically, if they're on like a patch, I have them do that blood test the day after they change their patch, or maybe the second day of their patch, just to see where they're landing. And what level am I looking for? I'm looking for absorption. So if you're fully postmenopausal, your estradiol levels should be fairly low. So I'm
Yep.
looking for anywhere between 20 and 100. There's not one level where this person's symptoms are going to resolve, but I want to see that they're actually getting a level from this patch. I've had some patients who have a patch on and they register at 5 and they're on a zero point 0.1 patch. And then I'm like, okay, you're not absorbing from that.
Yeah.
We're changing tact. We're either
Yep.
going to go to oral. Sometimes, if like even in oral they're not absorbing well, I'll have them dissolve it sublingual, which doesn't taste very good, but gets it straight into the bloodstream a little faster. Or, that's when I sort of write the prior authorization and say they need a femring. I can't, like, I've tried all the other things.
Yep. Yep. We gotta do something here, people. Well,
Somebody asked a really good question about endometrial protection with GLP-1s and PO meds. And the
yeah,
answer is we don't know.
I
We got
know.
nothing.
Some
Progesterone's
people absorb
already
just
hard to absorb.
yeah. I don't know. I mean, some people absorb all their meds just fine. They have no
Yeah.
change. Like if they're on a thyroid, they have no change in their
Right.
TSH levels. Like they're great. They have no problem. And
Mhm.
then other people. So the main thing that I'll look for, the nice thing about if we don't have enough endometrial protection is you'll start spotting.
Yeah.
So that'll be a big thing that I'll sort of look for, or if they're like, hey, I was sleeping great and now I'm not sleeping at all. You're like, is your micronized progesterone being
Right.
absorbed? Like
Right.
maybe that's the reason we need to be trying to think.
If you have any concern, this is a great place for a marina.
Oh, always,
Yeah.
always a good place for a marina. The answer for everything in complex family planning is a marina, just in
Yeah.
case
There's
anybody's
that.
wondering.
Yeah.
Yeah, it's always the answer. Oh, and there's a question here about, are we looking for a specific level, which I think you sort of addressed, but there is a lot out there about targeting specific levels. Like you'll see a physician, they
Oh,
might
yeah.
start you on, or a provider, they might start you on estrogen, and then they start checking your blood levels because they want to get you, oh, you're still a little low, we have to go here. There's no target level of where you need to be for anything, for cardiovascular risk, or endometrial, like it sort for vasomotor symptoms, anything. Like there's no target level that you need to be at. It was interesting because I was talking about this with someone the other day, and they sort of feel like it came from like very old data from like a Spearoff book, where like there may have been like some guidelines
Right.
in that textbook about it, but that's not actually based in clinical practice. So it's
No.
really about like, are you absorbing and what are your symptoms? And that's how we titrate it.
Yeah. And I think this comes up most often. We're seeing a lot of people come in and say, well, I heard on TikTok that I need to be in above 50 for bone protection. And I think
Yes.
that's what comes out of the old Sparrow
Yeah.
text, which was not based on clinical trials, by the way, just so everybody
Oh,
knows. There has been a clinical trial with something called Menostar. You can look it up. Menostar was a 0.014
yeah.
patch,
Crazy
which isn't
pants.
even available anymore. And that showed good bone protection. So if that can do it, your 0.05 is going to be more than enough,
Yeah. No, agreed.
regardless of the level.
Yeah. Yeah. So that's definitely a good question though, because that's all over TikTok right now.
Oh yeah. I know it's just and people don't recognize that actually too much estrogen makes you feel like crap too. Like I
Yes.
have patients who says high
Horrible.
flashes come back on pellets because they're way up in like the 3, 4, 500s.
And you can feel
There's a reason
awful.
you feel like such ass in perimenopause. Let's not do that to women again.
No, yeah, no, 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 it's bad. It's bad. I mean, you can have hot flashes. I mean, like
Yeah.
it's paradoxical, right? Like you
Yeah.
feel so crummy, and then they'll be like,
Yeah.
"You need to give me more." You know, like, let me just check and see if you're absorbing. I'm like, well, you're in the 700s.
Yeah.
Let's take a break and
Yeah.
let's
Yeah.
suppress your ovulation and see if we can make that better.
Yeah. All right, everybody. This has been a wonderful session. Thank you again, Amy. I always enjoy
Yes,
talking to you. You know that. We talk to each other
I
every
know.
week. But
Yeah. But thank you so much for having me. It's always fun to
yeah,
come on, and it's great to have all these great questions and be able to answer them live. So thank you so
yeah,
much. It's a great topic. So
yeah.
I appreciate being
Excellent.
here today. Thank
All
you.
right. Have a great night, everybody. Thank you.
Bye.